Welcome to this deep dive, especially tailored for you. Today we're tackling a really significant area in cancer care, chemotherapy-induced neutropenia.
It's a big one, definitely.
Yeah, and you've shared a fantastic collection of resources with us, chapters from DaVita EORTC Guidelines, West Midlands Cancer Alliance Guideline, McGill's Hematology Oncology Therapy book, and a handbook on symptoms, too.
Good stuff. Lots to unpack there.
Absolutely. So our goal today is to really break down what this condition is, how it's different from other causes of low neutrophils, what the labs tell us, how it's managed inpatient versus outpatient.
Right, the practical side.
Exactly. And why that absolute neutrophil count, the ANC, is so vital. Plus, when to think about G-CSF.
Granulocyte colony, circulating factory.
Antibiotic strategies. And finally, what the sources say about, prognosis and risk.
Okay, sounds like a plan. Where should we start?
Let's start right at the beginning.
Yeah.
The cause. What actually causes chemotherapy-induced neutropenia?
So, chemotherapy, as we know, its job is to go after rapidly dividing cancer cells.
Right.
That's the target.
Right.
But the issue is it's not always perfectly selective. It can hit other cells in the body that also divide quickly.
Collateral damage, sort of.
Exactly. And that includes the cells in our bone marrow that are busy making blood cells, specifically neutrophils.
Okay.
So when the chemo suppresses that production line in the bone marrow, you end up with fewer neutrophils. And that's chemotherapy-induced neutropenia, a lowered count of these really key infection fighters.
That makes sense. But the materials we've been looking at, they mention other reasons someone might have low neutrophils, too.
They do, yeah. It's important to distinguish.
So how is the chemo-induced kind really different from, say, those other conditions?
That's a really key point. McGill's book, for instance, it specifically lists things like congenital neutropenia, cyclic neutropenia, idiopathic neutropenia. These are separate things entirely.
Okay, so not treatment-related.
Right. They have their own causes, nothing directly to do with cancer treatment. And then, the DaVita text, when it talks about infections in immunocompromised folks, it mentions other possibilities, too. The cancer itself, like certain blood cancers, can cause neutropenia. So can infections, viral, bacterial, fungal, even autoimmune disorders or reactions to other drugs, not chemo.
So lots of potential culprits.
Yeah. But the defining thing for chemotherapy-induced neutropenia is that clear timeline. It's directly linked to getting that myelosuppressive chemo. The treatment causes the drop. Simple as that, conceptually.
Got it. So when we're looking at lab results for a patient on chemo, what's the number one thing telling us, okay, this is neutropenia we need to watch?
Hands down, it's the absolute neutrophil count, the ANC. Generally, we define neutropenia as an ANC below 500 cells per cubic millimeter. Or sometimes if it's between 500 and 1,000, but we expect it to drop further, below 500.
Okay, 500 is kind of the magic number.
It's a key threshold, yeah. But what's really crucial, and the sources emphasize this, is not just how low it gets the depth, but also how long it stays low, the duration.
So time matters just as much.
Absolutely. One of the sources, I think it referenced a specific study, pointed out a direct link between how long someone has severe neutropenia and their chance of getting febrile neutropenia with a fever.
Okay, so a sustained low count is particularly risky.
Very risky. It gives infections more opportunity to take hold.
Which naturally leads us to management. DaVita outlines different paths for inpatients versus outpatients. What decides where someone gets treated if they develop, say, neutropenic fever?
Yeah, that decision hinges almost entirely on risk stratification, figuring out how high the patient's risk is.
Okay, how do you do that?
For adults, a really common tool is the MASCC Index Multinational Association for Supportive Care in Cancer.
MASCC, okay.
It helps identify patients who are likely at lower risk for serious problems. It gives points based on things like how sick the patient seems overall, if they have low blood pressure or COPD, the type of cancer, hydration. Are they already an outpatient, their age?
So it takes a lot into account.
It does. And you get a score out of 26. If the score is 21 or higher, that generally suggests lower risk. These patients might be okay to manage at home with oral antibiotics.
Might be. So there are other factors.
Definitely. They still need to be able to take pills, have good support at home, and quick access to medical care if things change.
Right, makes sense. But what about those who don't score high on the MASCC or have other issues? the higher risk folks.
For them, yeah, the approach is different.
Yeah.
The IDSA Infectious Diseases Society of America guidelines, they lay out clinical criteria for higher risk.
Like what?
Things like expecting the neutropenia to last a week or more if the patient is clinically unstable, maybe has significant other health problems.
Comorbidities.
Exactly. Or if they're getting really intensive chemo. ASCO, the American Society of Clinical Oncology, has similar criteria too, pointing out situations where someone is high risk even if their MASCC score looks okay.
So multiple checkpoints to catch the high-risk patients.
Absolutely. The main goal is to get those more vulnerable patients into the hospital for IV antibiotics and closer monitoring.
Okay. And for those low-risk patients managed at home, what kind of oral antibiotics are we talking about?
Well, DeVita mentions a key thing first, making sure they can actually take the oral meds and get follow-up care easily.
Crucial practicalities.
For sure. Then common regimens often include ciprofloxacin plus amoxicillin clavulanic acid augmentin.
Okay.
Or sometimes moxifloxacin on its own, unless they've already been taking a similar drug, a quinolone, for prevention.
Right. Don't want to double up or use something ineffective.
Exactly. And if someone's allergic to penicillin, then ciprofloxacin plus clindamycin is a typical alternative.
Okay, good options there. Now let's switch to the hospital setting. Those high-risk patients needing 5E treatment. What's the usual first step?
For high-risk neutropenic fever needing admission, the standard is prompt, like really prompt, broad-spectrum IV antibiotics.
Get them started fast.
Immediately. Often, the first choice is what we call monotherapy, just one drug using a beta-lactam antibiotic that works against Pseudomonas aeruginosa. That's a common and nasty bug in this situation.
Examples.
Things like piperacillin tazobactam, Zosyn, or imipim, meropenem, cefepime, ceftazidime. Depends a bit on the hospital's local resistance patterns.
Right. What bugs are common there and what works against them?
Precisely. Now, the guidelines do say to consider combination therapy, maybe adding a second drug if the patient is really unstable, or if you suspect resistant bacteria like MRSA or resistant gram-negatives.
So maybe adding vancomycin or another gram-negative agent?
Right. But routine combination, like adding an aminoglycoside to the beta-lactam for everyone. The evidence suggests it doesn't necessarily improve outcomes overall and can add more toxicity, like kidney problems.
Interesting. So monotherapy is often preferred if possible.
Often the starting point, yeah. Some analyses even suggest piperacillin tazobactam strikes a good balance between being effective and having lower toxicity. But again, local data is key.
Okay. Let's shift gears a bit to those G-CSF's granulocyte colony stimulating factors. The EORTC and West Midlands guidelines talk about when to use them. When do you typically start them right from the get-go as prevention?
Yeah, that's called primary prophylaxis, using G-CSF from the very first chemo cycle to prevent febrile neutropenia.
Prophylaxis, okay.
The general rule of thumb, based on guidelines, is to recommend it when the chemotherapy regimen itself carries a high risk, usually defined as a 20% or greater chance of causing febrile neutropenia.
A 1 in 5 chance or higher?
Pretty much. But it's not just the chemo regimen. Patient factors matter too, like being older, say over 65, or having had lots of chemo or radiation before, poor performance status, existing neutropenia. These things bump up the individual risk.
So you might use G-CSF even if the chemo risk is slightly below 20%.
You might, yeah, if the patient has several of those risk factors. Also importantly, for chemo regimens that are dose-dense or dose-intense, meaning more chemo given more often to try and improve cure rates.
Right, pushing the dose.
G-CSF is often essential just to allow that intensity, to keep the count up enough to give the chemo on schedule. The West Midlands guideline even notes specific regimens where G-CSF is basically considered part of the package deal.
Integral to the treatment plan.
Exactly.
So that covers preventing the first episode. What if a patient does get neutropenic fever or severe neutropenia, despite not getting G-CSF initially? What about using it in later cycles?
Right, that's secondary prophylaxis, using G-CSF in subsequent cycles after an event has happened.
Does that always happen?
It's definitely considered. But the guidelines, like West Midlands, often stress that the first thing to consider, especially if the treatment goal is palliative, is reducing the chemo dose for future cycles.
So dose reduction first, maybe.
It's a key consideration. Secondary prophylaxis with G-CSF might be used alongside a dose reduction, or if maintaining the chemo dose is really critical for the treatment's potential benefit, G-CSF might be added to try and prevent another episode at that same dose.
Yeah.
It's a bit of a balancing act.
Trying to keep the treatment effective but safer.
That's the goal. Prevent future problems while ideally still getting the job done with the chemo.
And once you start G-CSF, how long does it typically continue? When do you stop it?
Usually it's continued until the ANC recovers to a safe level. That safe level is generally considered back above 500 cells per cubic millimeter.
Back above that threshold.
Yeah, and the DaVita text also mentions, thinking about patients with persistent fever, that they should ideally be a febrile, no fever for at least 24 hours as well, alongside the count recovery.
So count recovery and fever resolution.
Those are the main markers for stopping, typically.
Okay. Now, sometimes, despite the broad-spectrum IV antibiotics we talked about, the fever just hangs around. What do the sources suggest then?
Yeah, that's a concern. DaVita points out that, on average, fever usually breaks within about 4 days of starting good antibiotics.
But if it doesn't, day 5, day 6, still febrile.
Right. If it persists beyond that 4-7 day window, despite the antibiotics, you really have to start thinking strongly about an invasive fungal infection, an IFI.
Fungal infection.
Okay.
Right.
So the recommendation then is to do more diagnostic workup. Maybe get a chest CT scan, run specific blood tests, serologic tests, looking for fungal markers.
Trying to find evidence of fungus.
Exactly. And you might empirically add an antifungal medication at this point. That means adding it based on suspicion, even without proof yet, especially if the patient wasn't already on some kind of preventative antifungal drug.
And what antifungals are options there?
Common choices mentioned include amphotericin B formulations, voriconazole or caspofungin. Depends on the situation. Suspected fungus, local patterns.
Got it. Now, the text also mentions something called preemptive antifungal therapy. How's that different from just adding an antifungal empirically if the fever won't go away?
Good question. It's a more targeted strategy. Instead of just saying, okay, fever for 5 days, let's add antifungal, the preemptive approach tries to use diagnostics first to identify patients who are more likely to actually have an IFI.
So using tests to guide the decision.
Right. Using things like those CT scans we mentioned or specific blood test serum biomarkers like galactomannan and beta-D-glucan assays. These tests can sometimes detect fungal components early.
Beta-D-glucan. I've heard of that.
Yeah. It's useful for picking up various fungi like Candida, Aspergillus, and others. Not perfect for everything, doesn't reliably detect mucormycosis, for example, but it's another
More targeted, less shotgun approach.
sort of, yeah. It's an evolving area trying to optimize when and how we use these drugs.
Makes sense. Okay, lastly, let's touch on prognosis. What do the sources tell us about the outlook for patients who get chemotherapy-induced neutropenia, and how do we assess their overall risk level?
Well, that MASCC score we talked about for deciding outpatient versus inpatient, it also acts as a pretty good prognostic indicator.
Lower score means worse prognosis.
Generally, yes. Lower MASCC scores correlate with a higher risk of complications during that neutropenic episode. And several other factors flag a potentially poorer prognosis, too.
Such as?
The West Midlands guideline mentions things like having really profound neutropenia, very low counts, that last for a long time.
That duration thing again?
Exactly. Also, if the underlying cancer isn't well controlled, if the patient develops pneumonia, has low blood pressure, signs of multi-organ problems like sepsis, developing an invasive fungal infection, obviously, is bad news prognostically. And even just being sick enough to require hospitalization right at the start of the fever can indicate higher risk.
So, lots of warning signs.
Yeah. And it all circles back to what we said earlier. Rapid diagnosis and getting the right treatment started quickly for neutropenic fever is absolutely critical for improving outcomes. Time is really of the essence.
So, wrapping this up, it seems like chemotherapy-induced neutropenia is, well, a major hurdle in cancer treatment, but one we're getting better at navigating.
Definitely. Our understanding of the causes, management, risks is constantly improving.
And it's clear there's this real interplay between, how low the counts go, how long they stay low, the patient's overall health, the specific chemo. It all feeds into the care plan.
Absolutely. It's complex. Tools like MASCC and the IDASCO criteria help guide those big decisions like hospital or home. And G-CSFs are, well, indispensable, really, for prevention and mitigation in many cases.
And that point about persistent fever really highlights the need to stay vigilant for infections, especially those tricky fungal ones.
You have to keep a high index of suspicion, definitely.
What really strikes me is just how many different pieces need to fit together. You've got the lab numbers like ANC, but also the big picture clinical status, the treatment goals.
It really underscores the complexity of cancer care, doesn't it? And why that personalized approach is so vital.
Totally. This deep dive, I feel like we've covered a lot of ground, but it's still kind of a snapshot,
Oh, absolutely. Each piece antibiotic choices, G-CSF nuances. The whole world of antifungal therapy could be its own entire deep dive. Easily.
Well, we really hope this discussion has helped provide a clearer, more comprehensive picture of chemotherapy-induced neutropenia for everyone listening.
Hope so, too.
And thank you so much for sharing your sources and letting us really dig into this important topic together.
My pleasure. Good discussion.
We definitely encourage everyone listening to keep exploring these resources, maybe check out those specific guidelines we mentioned for even more detail. Thanks for joining us for this deep dive.
Yeah, thanks, everyone. See you next time.